morning, everyone, respected judges and audience. My topic of presentation is corneal involvement among COVID-19, rhino-orbital cerebral mucormycosis, and treatment. It's not going. So as we all know, the second wave of COVID-19 pandemic has led to a huge resurgence of mucormycosis. More than 47,000 cases of mucormycosis they were reported in 3 months between April to June 2021. The fatality rates of cases reported from India were less than the globally reported cases, primarily due to predominance of rhino-orbital manifestation. During the first wave of COVID-19, India contributed to approximately 71% of global cases of mucormycosis in patients from December 19 to the start of April 2021. The reported mortality obtained from India was much lower than the previous Indian data on known COVID mucormycosis. The crisis of mucormycosis was further worsened by an acute scarcity of the amphotericin B, which was caused by the large number of cases of mucormycosis. The organism primarily which was responsible for mucormycosis was Rhizopus erizus, followed by other species. Rhino-orbital and the rhino-orbital cerebral mucormycosis were among the most frequent presentation of mucormycosis. Our orbital mucormycosis and cerebral mucormycosis, they accounted for 89% of cases in India, while globally they accounted for only 64%, where the pulmonary mucormycosis was more prevalent. The risk factors, diabetes remained the most important risk factor pre-COVID and post-COVID era, followed by the hematological malignancies and organ transplant and neutropenia. As we all know, these spores are ubiquitous in nature, so these are being inhaled and then they deposited in the nasal turbinates. In the lower respiratory tract, the macrophages and neutrophil, they phagocytose these Cornea. But a patient who is on glucocorticoids and who has a neutropenia, this is inhibited and this led to the proliferation of hyphae. The hyphae gets proliferated even under the high iron support. So a patient having iron supplements or iron overload or hyperglycemia or who is on glucocorticoids, these hyphal proliferation gets supported. Later on, this hyphae, they go under dissemination, and this lead to basically the main pathophysiology behind this is the angio invasion leading to the hematogenous spread, contiguous spread, and then various manifestations. The COVID-19 associated risk factors were again the COVID worsening or the induced diabetes, the injudicious use of steroids, the high ferritin in COVID-19. For the treatment of mucormycosis, lipid formulation of amphotericin B was favored because they were less nephrotoxic than the deoxycholate forms, especially when given in high doses. 2 other azoles, isavuconazole and posaconazole, were also emerged as a viable alternatives. So the material and method of the study, it was a retrospective observational record-based data of 32 patients out of 22 rhino-orbital cerebral mucormycosis, which were admitted at a tertiary care center. The inclusion criteria were confirmed cases of invasive mucormycosis, either clinically on 10% KOH microscopy or on radiological imaging. Invasive mucormycosis patients with corneal, ocular, or ocular surface, ocular coat manifestations. The following parameters were recorded. Mostly the patients were in neuro wards, so only the torchlight examination could be done. But still we tried to take the visual acuity, pupillary reactions, extraocular movements, facial symmetry, orbital signs, Schirmer test, the corneal ulcer, the size, shape, site, the corneal sensations, anterior chamber status, sedals and lens status, and the fundus examination was evaluated. Corneal staining pattern was also evaluated. Corneal scraping as and when feasible, because the patients were not able to sit on the slit lamp, they were on critically ill. The conjunctival swab, pus KOH, and gram staining was done. The treatment which was offered to all of these patients was the systemic liposomal amphotericin B, oral posaconazole if a patient was allergic to amphotericin B, topical amphotericin B in a concentration of 0.5 mg per ml, 0.05%, lubricants, anti-glaucoma, and cycloplegics. So the results of the study, the primary outcomes were taken as the time for the epithelialization, the decrease in the ulcer size, in the infiltrate, the depth, which was done only on the torch light. The secondary outcomes were the symptomatic relief to the patient as symptoms begin to resolve prior to the improvement in the objective clinical appearance.
Dr. Rekha, please come on your results.
Yeah. So the result, the mean age was 52.84, there were 22 males and 10 females. 29 patients were diabetic, 32 had recent COVID-19 infection. As we all can see that there were 9 patients with the corneal ulcer, 3 patients with corneal melts, 6 patients with diffuse corneal punctate staining, and rest all the filamentary keratitis. One was having filamentary keratitis, and 1 each with limbal ischemia, corneal haze, pan-off. So this table shows that there were 6 patients which got expired, the 6 got exentrated. Out of 32, the 20 patients of corneal ulcer and rest of the corneal problems, they got healed. Only 1 showed a recurrence and 1 lost to follow-up. Just a last slide. This shows that the first one shows the orbital signs with the corneal sloughing and the corneal ulcer. The second one shows there's a limbal perforation with the collapsed anterior chamber and DM fold. Third one shows the positive sedals and inferior corneal ulcer. The fourth figure shows posterior synechiae and the corneal haze. This is the typically presentation, the central corneal ulcer with a larger in size involving the central and the paracentral area. This was the patient with the corneal stromal abscess and the pan-off with the lid eschar. This was the exposure keratopathy in the central area.
I think you can just conclude maybe on last slide.
Yeah, so this is the last slide. This shows the pre-treatment and this is the post-treatment where a patient got healed with the inferior macular opacity. This was when there's a spontaneous healing of the scleral perf leading to maintaining of the anterior chamber. This was, again, healed corneal ulcer. This was the complicated cataract. And this is when we did a tarsorrhaphy in a patient with a central corneal ulcer, got healed. And this is, again, the big corneal ulcer which got healed, which is in the process of healing, basically. Thank you.
So what take-home message do you want to convey?
Ma'am, actually, we don't have much in the literature about the corneal manifestations in mucormycosis. We read about the orbital, the posterior segment. This is just to add on to what all can happen in a patient of mucormycosis. And we only started them on amphotericin and the supportive therapy. So these were the results. Maybe we can try amphotericin. This is just to add on the corneal, basically corneal and the anterior segment manifestation, which is like less in the literature.
So how did you move about the treatment?
Sorry, ma'am?
What was the preferred drug which you gave?
Ma'am, in a patient of corneal ulcer, we started them on topical amphotericin on a concentration of 0.5 mg per ml with cycloplegic and anti-glaucoma treatment. But few of them, they had presented with only diffuse corneal staining, which got healed with frequent lubrication and lubricant eye ointments. And there was 1 patient with the uveitis. We started that patient on routine predecetate and routine cycloplegics.